Welcome, everyone, and thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. This is my 17th year on active surveillance. 17 years ago, I was told I was a great candidate for surgery, and I'm sure I was. Our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment, but a management plan. I would like to remind everyone that we are not anti-treatment, but anti-unnecessary treatment. We are not here to dispense with any medical advice. Nothing said during our meetings by our speaker, ASPI, or the audience should take the place of consultations with your medical professionals. We're going to hold all questions until after the speaker's presentation. You can submit questions in the chat box, which we will try to address. You can also click the raise hand button from the bottom of the Zoom window, and if there's time, we'll try to call on you. Please keep your questions limited in scope. Our time here is limited, and our speaker does not have time to review your case history. During the meeting, please keep yourself muted. The speaker presenting here today is generously donating their time, and we want to be respectful of that. This meeting is being recorded and will be available on our website in approximately 1 week, and you will get an email notifying you when it's ready. I'd like to remind everyone we also have a separate page of 1-minute video shorts derived from each of our meetings. Last, if you subscribe to our YouTube channel, you will automatically be notified whenever a new video is posted. I'll quickly add that we're always looking for volunteers, so if you have some time to help spread the active surveillance word, please get in contact with us. I would also like to put in a short plug for ASPI. We are largely a volunteer organization. Though we are a nonprofit, that doesn't mean it doesn't cost money to do what we do. So, if you can help us continue our mission of active surveillance education, please go to our donate page on the website. We greatly appreciate your donations, and no amount is too small. This coming September, the annual Prostate Cancer Research Institute conference is taking place in Los Angeles, and it's a very worthwhile conference to attend. If you do attend, you can go to their website, PCRI.org, to register. And if you use the code SG, that's in capital letters, for support group, you'll get a 50% discount. So, without further ado, we will have a few quick words from Mark Lichty, our chairman, who will then turn the meeting over to Howard Walensky, the organizer of this meeting, and introduce our guest. So, relax, enjoy the meeting, and I hope you leave a little bit smarter. Take it away, Mark.
My name is Mark Lichty. I'm chair of Active Surveillance Patients International. I have my wife, Wendy, packing the car for our vacation up the Hudson River. She's a good wife. Anyway, I'm really interested in hearing about de-intensifying active surveillance. Last month's talk was fascinating. I just all about biomarkers. If you didn't see it, go to the website and take a look at it. I missed it because I was at a good friend's 80th birthday party, but I really found it very one of our best webinars. And I also, in terms of the information that we provide, I again recommend our ebook. If you haven't read our ebook, it's the best thing out there on active surveillance. And again, we're the only ones that are doing these 1-minute shorts. If you have an issue, go to our website and put your question in there, and you'll come up with a 1-minute short that'll get you information that you need to answer your question. Um, so we're going to stick around afterwards because we found that men really yearn for we call it a workshop. We could call it a sport group,
Wait a
but we
minute.
call
Did you say urine or yearn?
it. Uh, okay.
Have we
Uh,
recovered the audience?
After that, I think we lost him again. Anyway, um, so that's all I have to say. I don't want to take your time because we're getting off to a late start. So I want to introduce my good friend Howard Walensky, who comes up with these brilliant webinars. And so, Howard, you're the one who will introduce the speaker today. Thank you.
Great. Thanks, Mark. Greetings from Chicago, um, where we're getting all the Canadian smoke. And by the way, that is linked to prostate cancer. Maybe not yours, but somebody else's. If you're on active surveillance, you already know the drill. PSA tests, MRIs, biopsies. Sometimes it feels like your prostate has more appointments than you do. Today, we're asking the big question, do we really need to keep doing all of this forever? Or, as some of us secretly wonder, can we safely get a little break? To help us sort this out, we're thrilled to have Dr. Michael Leapman from Yale University, a top urologic oncologist, clinical program leader of the Prostate and Urologic Cancers Program at Yale Medicine. I think it's Bulldogs, so go Bulldogs, right?
Yep.
He, yeah, one of my brothers is a Bulldog, um, former high school dropout. At any rate, he Michael Leapman is a leader in early detection, biomarkers, imaging, and smarter, more personalized active surveillance. Dr. Leapman will walk us through how age, cancer grade, MRI findings, PIRAD scores, PSA trends, biomarkers. Somebody said, Ray, turn yourself off. Um, can can see how can we safely stretch out testing? Fewer biomarkers, fewer MRIs, longer intervals without losing the safety net. Please drop your questions into the chat room as we go along. We'll gather them for questions and answers at the end. And if you can't stay for the whole session, you're registered, so you'll get a copy of the complete recording. But don't leave us yet. We've already left once. With that, let's get started. Please welcome Dr. Michael Leapman. So, Michael, the floor is yours.
Thank you so much, Howard, for the kind introduction, and I'm really thrilled to be here. You invited me months ago, and I've really been looking forward to this date, and I'm just so delighted to speak to such a large audience on a Saturday. So let me share my screen. I think I'll need to be allowed to share screen. Okay. And so, I appreciate also the thoughtful, you know, question, right? How can we um, demystify surveillance and how can we really safely reduce testing? How do we de-escalate and de-intensify over time? I will say that we know a lot more about who qualifies for active surveillance in the early period, and so we have a lot of evidence about that. I'll disclose that we don't have a simple answer. I don't know that I'm going to walk away with a simple picture of what to do and how we can stop testing and who we can stop testing, but I'm really excited to talk about the developments that our field has made in progress towards that outcome, towards that question. So just a word about me. As Howard mentioned, I'm a urologist and urologic oncologist. I spend most of my time speaking with patients, doing surgery for prostate cancer, and every waking moment I'm not with my family or doing something fun, I'm really thinking about how we can optimize our existing treatments, how we can make better decisions and personalize decisions for prostate cancer, and particularly active surveillance. And so this is kind of what drives me. This is what keeps me up at night and gets me up early in the morning. So the outline for today, it's impossible to talk about de-escalating active surveillance and de-intensifying without providing some background. I know this is familiar territory to many or most on this call, but I think it's important to give some background about prostate cancer, low risk prostate cancer, intermediate risk prostate cancer, why we do surveillance, what we know about it, to set up that question. So first, by way of background, and I'll go through this quickly, Our prostates sit deep in our pelvis between our bladder and our urethra. They are adjacent neighbors to the rectum. And so anything we do in this neighborhood has the potential to impact our urinary life, sexual function, and bowel function. So this is valuable territory. We know that prostate cancer is the most commonly diagnosed cancer in men, behind or in front of lung cancer, and is the second leading cause of death. I always frame my discussions with patients by, just talking about how common prostate cancer is. And I'm not sure if this is a study that everyone on the call is aware of, but I think this really frames a lot of my thinking about prostate cancer. And this is a synthesis of numerous studies looking at autopsies of patients who pass away from another cause and look at how common prostate cancer is. And so when we go looking in men's prostates, regardless of their PSA level, regardless of whether they have symptoms or not, by the time a man's in their 70s, about more than a third will have some sign of prostate cancer. And once we're in our 80s, about half. And so it's there, and most of us never know it. Prostate cancer comes in many flavors, localized or advanced. For low-risk prostate cancer, which is really kind of the question of active surveillance, this is what we usually do not treat. We think about the intermediate risk bucket and the high risk bucket. Those are almost always treated, and then certainly in the advanced category. The grading is fundamental. I think I really need to just go back to that because this drives a lot of the discussion. The grade is what the cancer cells look like under the microscope, and it's the single most important number on our pathology reports, on your pathology reports. And so if you have a prostate cancer diagnosis, you almost always have had a prostate biopsy, or I would say always have had a prostate biopsy. And the grade group is a description of what those cells look like. Grade group 1, also known as Gleason 6, they are the slow-growing types, and there is no confirmed evidence of a spread of grade group 1 outside of the prostate. And that is why we even question whether that label should be applied to prostate cancer, because if it doesn't spread, it doesn't meet that fundamental definition when we think about cancer. There's a lot of heterogeneity above grade group 1. This is an area that I'm very interested in, is what about the grade group 2? This is the largest category of people diagnosed in the US. These are slow growing still for the most part, but they do have the potential to spread. They are different biologically. They have some of those teeth, some of that horsepower to get out of the prostate. Grade groups 3 and 5, we won't talk too much about those today because these are faster growing, and in people who are, in good health, we treat almost everybody because there is potential for spread. We know, fortunately, that survival is excellent overall, especially when we catch prostate cancer early, largely because it doesn't really matter if we treat it or not. These were never destined to spread or cause trouble because we're doing such a darn good job at finding these things early. I'll breeze through the treatments here. We know we can remove people's prostates. It's a robotic surgery almost always in the United States now. Radiation therapy is another option, usually given in more treatments, but because of where the prostate's located, this can affect urinary function, sexual function, bowel function as well, and is not a guarantee of cure. The last one I get a lot of questions about, many emails from Howard about ablation. What about ablation? I think there's a lot of interest and enthusiasm on this topic, but these are using energy to heat, freeze, or pass electrical current through the prostate into a tumor or where we think a tumor is located and try to address the cancer that way. For cancer that has spread or metastasized, we offer systemic therapy. These are medications that go everywhere in the body that are trying to attack cancer. The foundation of these systemic treatments is reducing testosterone. And if we take testosterone away, prostate cancer almost always shrinks. But the problem is that over time, prostate cancer is smart and finds ways to live and proliferate and spread even in the absence of testosterone. And we have a whole array of other treatments that work even when testosterone withholding stops working. Okay, but now to the nitty-gritty, what we really came here for. The who, what, when, and why of active surveillance. So, I think we also need a working definition. What I think of active surveillance is watching a low risk or intermediate risk cancer closely and deliberately, with all intention of treating it if and only if it changes. And so that's an important distinction from watchful waiting. With watchful waiting, we have made the decision collectively, the patient's decision, family decision, and doctor are all on board that we're not going to do anything unless there is symptomatic progression. If someone develops symptoms, pain, difficulty urinating, we'll treat then, but we're not going to go looking for early signs of a change. Active surveillance is not refusing treatment. We keep treatment in the discussion and we're constantly dynamically asking the question, is now the right time for treatment? Last thing, and I think relevant to our discussion, it is not a life sentence. So even though we start active surveillance, more than half need to be treated eventually. So this is really about timing of treatment. Okay, who is appropriate for active surveillance? This is really this strategy was really devised for low risk prostate cancer, grade group 1, low PSA, low clinical stage. Those are the foundation, the backbone for active surveillance. In the modern era, we also think that an MRI is very important to have before making a decision because often there are areas of more aggressive cancer that could be missed on a biopsy. So we want to know that we've actually profiled everything accurately and appropriately. We also think a good quality biopsy is necessary for that added certainty. The National Comprehensive Cancer Network and all clinical practice guidelines recommend active surveillance as the preferred option for most patients with low-risk prostate cancer. And there's a mountain of evidence that this sits upon. This is evidence from the Johns Hopkins cohort that have enrolled patients with low-risk prostate cancer showing incredibly low risks of death from prostate cancer or overall death in patients with low-grade prostate cancer. But I think the most important study, the single most important piece of evidence, comes from a trial done in the United Kingdom, started in the 1990s, where they took 1,600 men with low and intermediate and even some high-risk prostate cancer that was found by screening with PSA, and they flipped a coin. They did a randomized trial and put them into 3 categories. You either got actively monitored, surgery, removal of the prostate, or radiation. And they were followed for 15 years based on these individual allocations. Now, I should say that in the group that were told to be actively monitored, what they received is very different than I assume most guys on this call are receiving with active surveillance, because they were very seldom getting a repeat biopsy. There was no MRI at the time. There were no genomics. So they were pretty much getting PSA testing ad hoc, maybe another biopsy, but it wasn't mandated. And again, it was a mixed bag. It wasn't all the low risk baby prostate cancer. There were some that actually had some teeth. There were some that were slightly more aggressive. So we have a lot of information from this study about what happens in the long term when we monitor prostate cancer and when we do so at arm's length rather than very intensively doing biopsies every year and questions like that. So I think this study is telling us what are the consequences of starting with active surveillance, understanding that sometimes we have to cross over. So why do we do it? Of course, the real reason is to reduce side effects, bowel, urinary, sexual function, as well as the rare side effects, the kind of the horror stories you might hear among friends, among family members, bad things that can happen with treatment. So let me toggle back to the PROTECT study. So this is the published results, and I'm going to try not to show too many figures and graphs and tables, but what this is kind of the trajectory of patients over time. And it's pretty rare in medicine to see lines that don't separate like this. Basically, the survival was perfect no matter what you did at first, or if you had surgery, radiation, or active monitoring, these lines are inseparable. So I think my take-home points from this study, just to recap, is that starting with monitoring did not shorten people's lives. There was treatment did slightly reduce the risk of the cancer spreading, but didn't change the risk of dying. There are side effects of treatment, such as leakage, bowel problems, or erectile dysfunction with treatment. And monitoring is not doing nothing because many patients eventually were treated. Um, and also, the monitoring that those patients had was pretty much out of date compared to what we're doing right now. So, a second question I think that we need to also pull in when we're talking about active surveillance is what about the intermediate risk group? Okay, so we were talking first about the low risk group, which is still the lion's share of active surveillance, but what about those patients with a little bit more aggressive prostate cancer? Okay, a little bit of grade group 2, maybe a slightly higher PSA level or a slightly higher stage. And this is the biggest group of men in America with prostate cancer. 2/3 of prostate cancers fall in this intermediate risk category. And the low grade group is slowly and quietly going away. We are actually finding less and less low grade prostate cancer and finding more intermediate risk prostate cancer. We published a study recently in JAMA looking at trends in the use of active surveillance for intermediate risk prostate cancer with many of our colleagues who some of you might recognize from these calls, Stacy Loeb, Dr. Catalona, Matt Cooperberg. And we found that this is the biggest segment of growth in active surveillance. So more and more patients are interested in monitoring slightly more aggressive prostate cancer because we know the outcomes are good if we select carefully. Okay, how do we do it? The what of active surveillance? And so, it really comes down to those basic fundamental monitoring strategies: PSA testing, MRI, and biopsy. Just about everybody gets this at diagnosis. I feel quite strongly that that needs to be repeated in almost everybody at the 1 year mark to make sure that we have accurately profiled people and not missed more aggressive prostate cancer. In our institution and in my practice, we do continue to monitor quite closely with PSA testing every 6 months, another MRI every year or every other year, and questionably another biopsy. And that's kind of getting to the heart of the matter. Is that biopsy going away? So let's draw it out now and take the more full vantage, because I think we're not worried about 1 year, 2 years, 3 years, but we need to think about the long term. What is going to happen in the entire life of a patient who's diagnosed? So let's start stretching it out beyond 3 years. And what our practice consists of now is continuing to do PSA testing because it's easy, people are already getting blood work, so let's keep doing it. MRI is really quite important, but if there's not any evidence of reclassification or high risk features, that biopsy generally doesn't happen again until year 5. And MRI slowly becomes less frequent. And so empirically in our practice, we are de-intensifying. We have moved from doing MRIs and biopsies and PSAs every single year. When I started doing this, we would see patients who had biopsies every single year, even if they were negative or even if they were unchanged, we just kept doing them. That is slowly going away across the United States. There are downsides of surveillance. We know that it causes anxiety. Most men have some amount of cancer-related anxiety, and the idea of an untreated cancer in their body certainly triggers that. It's time-consuming. People spend a lot of time in appointments. There's a concern about needing eventual treatment, undergoing invasive testing, and developing a complication from invasive testing like another biopsy. There's also a lot of uncertainty about, am I doing the right thing, right? Well, my friend was getting monitored with just MRIs or was getting a PSA every 3 months. Why am I getting it every 6 months? And of course, there is a very low but real risk of true progression, something that gets out of the prostate. And even though that's quite rare, that is still a big concern for everybody. So can we safely do less to avoid those risks of invasive testing, anxiety, and uncertainty? So I conceptualize this the way I think about it. It's really 3 questions. Can we test less often? Can we stretch out the gaps between biopsies and MRIs once things look stable? Can we also test for fewer years? Can we maybe do more invasive testing in the beginning and then begin to back off? And third, can we test differently? what are we doing in terms of non-invasive biomarker testing with blood, urine-based biomarkers that still maintain testing, but do so in a way that is much more appealing. So what does the evidence tell us? Fortunately, we are now in the period where we can start looking back on patients who have done surveillance for over 20 years. There are many big academic studies that are publishing on this and reporting on it. One of the big ones is from Toronto, from Laurie Klotz, that have published on over 20-year follow-up of men with low and intermediate grade prostate cancer, showing excellent outcomes. They do have a slightly higher risk of metastasis compared to some of the other cohorts, about 3%. But what we're seeing consistently is still about more than half were still monitored and untreated by 15 years, even when you significantly ramp down, scale back the intensity of monitoring. The Canary Pass cohort is run out of Seattle, Washington, and that is a much more intensively monitored protocol. Those patients really sign up for a very protocolized, systematic protocol of biopsies periodically. With that protocol, there is a lower risk of cancer spread, 0.1% risk of dying from prostate cancer, and showing that we're seeing something that's really equivalent or in the same ballpark, even with a more hands-on or more hands-off approach. One of the first things we're trying to do is say, who is the profile of an individual that we can begin to scale back? And the folks we're most comfortable with are those who look really quiet for the first 5 years. And this was a study out of UCSF that looked at over 700 men with low-grade prostate cancer who had 3 biopsies and no sign of progression. Okay, so these are people we are quite confident have been profiled very well, and they wanted to look forward and see what happened in the next decade. So for folks who started and were very quiet in the first 5 years, majority never upgraded again. About 3/4 never needed treatment in the next 15 years, and 98% remained free of metastasis, and nobody died from prostate cancer. So I think one of the take-homes here is that for people who've had 5 years without any evidence of reclassification, with all of the close intensive monitoring, the risks really seem to go down. Okay. One of the caveats, I think, is that many of these upgrades, when we do see change, are probably actually quite minor. Going from a grade 1 to a grade 2, that is a change that is important, but it's not a major upgrade, and that doesn't mean the cancer has progressed. So I think this is one of the first kind of takeaways that, yeah, if you've got a favorable trajectory in the beginning, it's likely to stay that way. This is evidence, and this is data we published looking at Medicare beneficiaries in the United States, showing that, asking the question, what are we actually doing in the United States? And we looked at the frequency of biopsies, MRIs, and PSA testing. And what we found was that naturally, this is already going down. And so this is not just my data, this is national data across all Medicare beneficiaries or a subset of Medicare beneficiaries that's nationally representative. And rates of PSA testing, which is in orange, are going down. About 50% by year 10 really stop doing PSA testings. MRI really and biopsy begin quite high in the first few years, but ramp down over time. And so we need to adapt our approaches to meet what we're seeing as a patient request and a patient need to, de-intensify monitoring. So back to the question of who are the candidates that we need to monitor more carefully. So we've seen that if you have a very quiet initial period, you're more likely to stay quiet. What pushes the risk up? Okay, so if on an individual's initial biopsy, there's more cancer in the biopsy cores, there's a higher risk of progression over time. If the PSA level is higher, there's a higher risk of progression over time, as well as changes in the kinetics of PSA. So clearly, a rapidly rising PSA should trigger us to do a biopsy. What about a lower risk? So having a clear biopsy, and so what's called a negative biopsy. So if someone has prostate cancer, even if it's low grade on their first biopsy, if their second or third biopsy shows no cancer, which sometimes confuses people, how could you have a biopsy without cancer? The reason is it's probably so small, and that's why it's not picked up. That's a very good prognostic sign. Another factor is a larger prostate because that results in a lower PSA density, and so it's more suggestive of some of that PSA being driven by benign tissue. So the data seems to show that having clear biopsies, stable, especially, is a very good sign. So if you've had one biopsy that shows no prostate cancer after your first one, that's a favorable prognostic sign and an indication that we can maybe ramp down the intensity of monitoring over time. So the other way we talk about de-intensifying is we're still doing surveillance, but maybe we move from doing biopsies to doing non-invasive testing like imaging. So the most exciting development in prostate cancer, I think, and localized, has been the use of prostate MRI because it's giving us a window and a picture into prostate and prostate cancer that we never had before without doing invasive testing. We know a high quality prostate MRI picks up prostate cancer pretty darn well. We can see high grade cancers, especially if they're big. And if we have a clean MRI, that's a very good sign. So MRIs catch a lot of things, but I will say that the evidence shows it doesn't catch everything. Small things, 2-3 millimeters, are not going to reliably be picked up on an MRI. And so early grade changes can be invisible on imaging. What we are doing here is using the combination of a stable PSA and low PSA density with a quiet or stable MRI to stretch the amount of time between biopsies. And so for those folks that we're taking out to 5 years, those are people with good PSA kinetics and a stable, quiet MRI over time. But it is not yet ready to be seen as a replacement for biopsy. Many people are doing this, but I do not believe it's suitable to replace that confirmatory biopsy at 2 years because we do miss small things. This was a study that was a meta-analysis of multiple studies, asking the question of, can an MRI predict progression over time? We have been interested in this, and we've published numerous papers asking the question, what does an MRI tell us about a patient's trajectory over time? If an MRI shows a conspicuous lesion, a very solid appearing lesion, what will that tell us? And so if somebody has a PIRADS 4 or 5 lesion, which is something that the radiologist thinks is certainly real and likely to represent high-grade prostate cancer, they are more than double the risk of reclassification or progression over time. When we see a negative MRI, about 90% of the time, it's correct. There is not aggressive cancer. So when we see a quiet MRI that's not showing signs of prostate cancer, that is very reassuring. But significant cancers still hide from MRI and are invisible, which is why biopsy has not gone away. So my takeaway on this is that MRI is the best tool we have for deciding when to biopsy, but not good enough yet to replace it. Another question that we have looked at and are actively investigating is, do we need to do genomic testing? And I'll be curious to hear whether people in the audience have had genomic testing on their biopsy specimens. This is a very exciting question because it's pulling back some of the layers on the tumor to give us insight into what might be driving it. There are many tests on the market that are what's called genomic tests. And what they're doing, and sometimes it can be confusing, it is not telling you about your DNA, what you inherited from your parents, but it's actually looking at the activity level of genes that are associated with prostate cancer in the tumor. One of the tests that we use is called Decipher. It is a 22 gene test run on the biopsy tissue that has already been taken, and it reports out as low, intermediate, or high. And what they are trying to do is tell us the risks of metastasis and progression over time, because that's what we really care about. And so the data on this kind of goes both ways. We know that they do separate out and predict more aggressive prostate cancer, but I still think the jury's out about whether or not it's going to move the needle in the active surveillance space, and especially tell us who we need to monitor more carefully or less carefully. And so that's an area of active study for us and many other groups where we are looking at people who've been followed over the long term, and we're trying to determine whether the genomic report, that risk level, is a crystal ball and can tell us who we can truly de-intensify and walk away from and tell them you're at sufficiently low risk that you don't even need to worry about this, or we'll just monitor you at arm's length. And so, stay tuned on this. This is a very exciting question, and I think has the potential to change things, but more research is needed on this. So, kind of pulling it all together, what does less intensive monitoring look like? And this is kind of one way of putting this together. This is not kind of an official recommendation, but a way of thinking about it. In the early period, my take on the evidence is that we really need to confirm the status of prostate cancer in the initial period, right? This is where we want to make sure we get the diagnosis right. Was there a bit of high-grade cancer lurking in the anterior prostate that was missed on the first biopsy? Especially, I see a lot of patients for second opinions who've had a biopsy somewhere else. Maybe it was MRI guided, maybe it wasn't MRI guided, but we really got to be absolutely certain that there's nothing high grade or aggressive that was undersampled. PSA testing, since it's relatively easy, I think is a easy backbone to the story, and it gives us reassurance, but we have to be careful to not overreact to small fluctuations or changes, which do happen quite often. In the years 2 through 5, I kind of think of it like we're establishing stability. We're still doing PSA testing often. We're doing MRI every 2 years, every 1 to 2 years, and doing the biopsies every 2 to 3 years. By the 5-year mark, I think that's a good opportunity to take stock and see how things are going and begin asking the questions, can we start stretching these intervals out? Can we push the biopsy back 5 years or even longer, or even forego biopsy? I think age is a very important part of that story, okay? Because this is really a question of competing risks, the tortoise and the hare, right? What is going to be the biggest risk to any individual? Is it their non-prostate cancer causes like cardiovascular disease, smoking, modifiable risks? Because those significantly outweigh the risks posed by prostate cancer. And then later in life, I've been privileged to see men diagnosed in their 60s, but then we start following them in their 70s, 80s, and 90s. And when we're talking to folks in their 90s, we start asking the question, we're later in life, can we simplify this or simply stop and transition from active surveillance to watchful waiting? And, again, back to the definition we gave in the beginning, watchful waiting, we're thinking about not doing any monitoring and only looking for the development of symptoms. And if symptoms don't arise, we leave things alone. So a helpful way that I like to think about this is, what do we know very well and what are the open questions that we need to answer? So what I think we know well is that active surveillance is safe over 15 and more years, especially for grade group 1, and dying from prostate cancer is very rare in this group. Starting with monitoring does not shorten life, even in a randomized trial. Spread is not zero, but is the outcome we really want to avoid. If there is from the UCSF data, if there's a long active period of stability, that portends a fairly stable future. And so, I would count those stable years as a good sign that things are going to continue to be stable. What we don't know, and where we're really digging into, is which men with grade group 2 can stay on surveillance and for how long, who we can stop watching altogether and at what age. And I think this is something we really desperately need to invest resources and time and data into answering. Is MRI enough to replace a surveillance biopsy? It's happening empirically, but do we really know that this is a good idea? I think some of the most exciting data, and I haven't showed you any of the studies, but there are urine and blood-based biomarkers. There's a test called My Prostate Score that is being used in the diagnostic phase of prostate cancer, but they've just published a paper showing that it can predict upgrading on a surveillance biopsy. So it's possible that in the future, rather than getting an MRI and helping to decide when a biopsy needs to be done, it will be as simple as giving urine and testing that urine for markers of aggressive prostate cancer. So the other urgent questions that we need to answer that we're working on is, what is the role of genetics? I talked about genomics, what is seen in the biopsy. What about genetics? What about the inherited risk factors, like an adverse genetic profile? Who needs no monitoring at all? I think we may get to the point using a combination of germline genetics and profiling of the tumors to even identify a group who is so low risk that they never need to follow their prostate cancer again. We are not there yet, but I am hopeful and optimistic that we'll get to the point that we can identify trajectories well enough that we can even pull back any monitoring. And then to the same question, can monitoring be non-invasive? Can we sufficiently de-escalate to use only non-invasive tests, urine, markers, and imaging? So I wanted to close by just kind of getting ahead of and start stirring the waters about some of the questions that people ask me, because I think these are helpful. I always get the questions: does this run in the family? Is this a genetic thing? And what I tell people is that often it does. And I think it changes more what your relatives should do more than what you should do. We know that there is a family component. There are genetic factors such as a BRCA2 mutation or certain inherited mutations that definitely matter. People with strong family histories should be tested. And if you have a first-degree family member, particularly, so if you're a gentleman with prostate cancer and you have a son, that conversation should be moved up a little bit. What about diet or exercise? If I'm thinking about de-escalating my surveillance, can I just lean into diet and exercise and then that's going to help keep this away? In short, I don't think so. I think that diet and exercise are so important, and I'm a true believer in diet and exercise for our overall health. But just to put things in perspective, when we look at the risk of dying among men with prostate cancer, and this is data from that PROTECT study, when we looked at people over 15 years, less than 3% died from prostate cancer, but 19% died of something else. So you're about 7 times more likely to die of other causes than you are from prostate cancer. So those interventions can help people live longer, maybe without changing prostate cancer. Studies have been done looking at diet, supplement, and exercise. They haven't really given us a smoking gun. They haven't given us a clear answer, but it's a good idea. But I wouldn't look at it as an intervention that is going to make this go away or stop progression by itself. Can a biopsy spread the cancer? This is one I always get, and in short, I really do not think so. I have not seen any credible evidence of a case of prostate cancer being spread from a biopsy. There are some cancers we do not want a biopsy for that reason, but prostate cancer is simply not one of those. There are certainly reasons not to do biopsies: bleeding, infection, urinary issues, but I would rest assured that the risk of cancer spreading is zero or virtually zero. So I will stop there and conclude by saying that active surveillance is recommended for men with low-risk prostate cancer. We know that it is safe and avoids or delays treatment-related side effects, but we need to monitor. We can reduce the intensity of that monitoring. It's practical, it's a good idea, and it's already happening over time. The best candidates are people with low-risk features and, most importantly, stable features over time, and people who have had those initial monitoring tests for at least 5 years. But we need a lot more research to be done to help understand the second question: what happens in the longer term And can we even pare back what we're doing from the get-go? So I want to thank everyone for their time and attention, Howard for the friendship and kind invitation to be here today.
Michael, you did a great job, and real speaking for the group, speaking for myself, I think really delivered a lot of good points. But we're going to go through a round of Q&A and probably end on the half hour unless we have too many to handle, and maybe you could stick around.
Yeah,
But I have a question, actually a couple of questions from Eddie Green from Ipswich, UK. And I mean, to sort of boil down what he's asking, is de-intensification more of a grade group 1 question versus a grade group 2 question?
it's a great question. Um, I would say yes and no. Okay. We think grade group 1 is probably the low-hanging fruit for this question because the risks are so low, right? And Protect has shown us if you have grade group 1 and it's been adequately profiled, you know, those risks are small. Grade group 2 is a different category because those are cancers that do hold metastatic potential. And so, given it enough time, there are some of them that may truly progress. So, there are people with grade group 2. The majority of grade group 2s will never do that. But that is something we need to understand more about. So, I think grade group 1 will be maybe the first group that we can truly de-intensify. Grade group 2 is shortly behind.
Oh, he then asks or notes PSA increases is related to age rather than
Yeah.
worsening cancer. So then he says, this is another argument why I feel that another biopsy, even transperineal, may offer more risk than benefit. Having said that, nobody would want to miss growth in a dangerous tumor. It's a bit of a dilemma. So
It
that
is,
is,
right? I mean, those are the trade-offs. I mean, and it's a personal decision, right? I mean, the way I look at it is that people should be offered the opportunity to decline that biopsy. I mean, I give a strong recommendation to do that second biopsy for those reasons, but you are in the driver's seat. I mean, this is one of those things where it really needs to be coming from the patient, understanding all of the risks and the um, on the table. You're not going to find the aggressive cancer if you don't do the biopsy, right? PSA alone can be a fake out, right? It can rise for other reasons unrelated to prostate cancer, and it can be stable even in a cancer that is aggressive. And some of the more aggressive cancers don't reliably make a lot of PSA.
now I'm going to share a little personal information, but I'm not looking for personal advice, just more general.
Yep.
I just had a chat with my own urologist. I've been on active surveillance for 16 years. I've had, in the beginning, I had 6 biopsies. I had roughly 80 cores. Only one of them was positive, and it was 1 millimeter. And the next biopsy showed nothing. And
Hmm.
so life has gone on for 16 years. And in terms of intensity, I think I'm kind of de-intensified. I haven't had a biopsy in 10 years.
Yeah.
I last year for the first time in 9 years, I had MRI, but it was biparametric. And so in my discussion of my update, my PSA has gone up a little, but I'm pushing 80 years old, so give me a break. But the doctor said, that he thought I should continue on actually the prostate health index, which of course includes the regular PSA. But I'm wondering. Well, he said he thought that the continuing with PSA was important. But did I hear you say that there was a study where PSA testing stopped at year 10? If stable, was I dreaming that?
No, well, it's not that it's recommended, but we looked at what's actually happening in America. I mean, people are just choosing. It's kind of just falling off over time. And so, in my practice, I still do it because I think it's, look, if you're getting cholesterol and you're getting, basic blood work, why not do a PSA? It's got to be interpreted carefully. And to the point of, yes, as we get older, our PSAs on average go up because our prostates get bigger. Um, and so when we account for the size of the prostate, we shouldn't really be seeing a rise in PSA. And that's why the PSA density is a very important metric to calculate. That is the PSA level divided by the volume of the prostate.
Right. I think mine came out to like 0.07, something like that.
So there you go. So that's a really important thing to calculate to cut through some of the noise because I know it really rattles people when their PSA goes up a point or two over time, understandably. But if your prostate's gone up 10, 15 cubic centimeters too, that might just be the reason your PSA has gone up.
So is and my own doctor says de-intensification from his point of view mainly involves biopsies, but it doesn't involve
PSA.
PSA or PHI.
Yeah, I think so, but we may get to the point where maybe look, I think everyone's experience is different, but there's some people who start getting PSAs and the PSAs go wacky, and then all of a sudden, if your PSA goes up 5 points, you end up with a biopsy that you never needed, right? And so I think true de-intensification will probably drop biopsy first because that's clearly what we want to get away from. Imaging second, because imaging is a gateway to biopsy. Because if you do an MRI and you see a PIRADS 4 or 5 lesion, you feel compelled to biopsy it, right? So if you're doing an MRI, many cases you're going to end up doing that biopsy because you found something. And not everything that shows up is cancer.
Let me ask your thought on one more thing, and then I'll switch over to one of the other moderators. My feeling is 16 years ago, the goal was to keep you out of the operating room.
Yep.
Today, I feel that the goal is to reduce biopsies so that the next steps are not needed. And then maybe follow with PSA. Would that be fair?
I think that's a good way of looking at it. I mean, I think, everyone's goal is different, but my take on it is I want to keep people's length and quality of life as good as possible, right? So certainly if we're taking out someone's prostate or radiating them, their quality of life may go down. But biopsy is part of that. Biopsies are unpleasant. So if we're trying to preserve and optimize quality of life, that's what we're going for. And so reducing biopsy is part of it. It's not a defeat. I mean, doing a biopsy is not a bad idea, and we also need to be, I don't want to overstate the risks of a biopsy. It's an unpleasant day or two, but in many cases, it's the right thing to do. If we really think something's changing, we got to know it. So we shouldn't be afraid to recommend a biopsy, and I don't think patients should be afraid to go for the biopsy if there's a good reason to do it. Um,
I gotcha. Okay, I'll shut up for a few minutes and switch over to David Keller. David?
Hello, doctor. Fantastic. Can you hear me okay?
Yep.
Great presentation. Fantastic. I loved your overview and then you drilled into the details. It was wonderfully designed and presented. Thank you very, very much. That was great.
Thank you.
I've got a question from one of the last things that was talked about, the PSA density. If you've got a PSA density below 0.15, but you have a PIRADS 4 and a PIRADS 5 lesion, would you use the PIRADS 4 and 5 to move you into a biopsy as opposed to the lower PSA density?
It's a great question, right? Because we have all these different signals coming at us, right? That's the challenge in prostate. It's rare that all the signals align. So
Yeah.
I think the PIRADS 4 supersedes the PSA density in that case.
All right.
But I would say that in our data, if someone has a PIRADS 4 lesion, they have about a 50 to 60% chance of finding prostate cancer. Now, if your PSA density is lower, that maybe shifts you down to 40%, but that's still above a threshold where I think it's worth doing it. Where PSA density seems to come into play the most is if you have a negative MRI, PIRADS 1, where they don't see anything. And I think
Okay.
I'm trying to keep my eye on the chat where someone had a question, if I have a negative biopsy, what should I do? Negative MRI, what should I do? So that's what we do here at Yale. Most of us is if the MRI is negative, but the PSA density is high, we're probably still going to recommend doing that initial diagnostic biopsy.
Mhm.
PSA
Okay.
density is low and it's negative, maybe that's someone we can hold off on for a bit.
Thank you. I'll ask a couple more, then I'll turn it over to Jeff. The impact of finding IDC, perineal invasion, and crib reform. I think that does that automatically move a reading into grade group 2 if it's a 3+4? And how are you using that information on those three indicators?
Wonderful question. Yeah, these are really three things to kind of disentangle. So first one, IDC. Okay, IDC, you're right. That constitutes grade group 2 or higher. That's introductal. What that's talking about is kind of the pattern of what those cells look like under the microscope. That's a bad actor. IDC, introductal carcinoma, no surveillance. I mean, that's what we're looking. That's why we do these biopsies. If we were to find it on somebody,
Mm-hmm.
that's who you want to treat. Same for cribriform. There was a great analysis of the PROTECT study where some of my buddies did this study where they went back to the biopsies from 30 years ago in England and they dug them up and they said, well, who progressed? There were these rare metastatic cases. Who were these people? And one of the most important factors was crib reform. Crib reform is another adverse pathologic feature. So this is in the grade group 2s, so that constitutes grade group 2. But if you have cribriform structure of those glands, and that's for the pathologist to determine, that they were at much higher risk of metastasis. And that is
Okay.
not one you want to play around with. So if there's anyone who has grade group 2 prostate cancer who is doing surveillance or thinking about it, they should be sure that that the pathology has been read by an expert or someone who knows what they're doing and has asked that question, is there IDC or is there cribriform? Because it wasn't mandated to be reported and for a long time. So our folks report it now, but there may be people who they noted it and they never mentioned it. And then
Does
perineural invasion.
perineural invasion fall into that same group?
Interesting. No, actually. So perineural invasion means that they see some prostate cancer next to these little fine nerves that run through the prostate. That does not make you a grade group 2.
Okay.
And there are studies going both ways. So perineural invasion for most people is still okay for surveillance, but there's some evidence that people who have perineural invasion are at higher risk for upgrading over time, meaning finding a grade group 2. It doesn't mean I'm not aware of anything linking it to higher metastatic risk, but more likely to be treated over time. So I still offer surveillance to people with perineural invasion. But I just tell them we should watch you a bit more carefully.
Thank you so much. This was really helpful. Jeff, I'll ask one more question, then I'll turn it over to you. In the presentation, we were introduced to stage 2A and stage T2B through C. Is it important for us to understand what that terminology means?
Yeah, that's a great one. You know, our staging system is a little rudimentary, believe it or not. Okay, the way that it's defined, at least by all of the guidelines, is actually when the doctor does the rectal examination, can they feel a lump? Okay, so if it's palpable, it becomes a T2. If they can't feel it, then it's a T1. So
Okay.
So our system, this one is probably the least I wouldn't hang my hat on this, but if they feel like a T2C means they feel a hard spot on both sides of the prostate, that bumps you up a little bit. And so in practice, not many people have T2Cs these days because the MRIs are so good at picking things up. But if you did have a truly palpable nodule on both sides of the prostate, yeah, that's a cause for concern. MRI seems to be more accurate, but MRI does not officially count in the staging.
Okay. I'm going to thank you, Michael. I really appreciate it. Great answers. Great presentation. Jeff, I'll turn it over to you. If you're there.
Well, if Jeff isn't there, about Rochelle. Rochelle, do you have something?
I do. I see Jeff, but I can't hear him.
Why don't you go ahead and
Okay. Well, Jeff sorts that out. So there are a few questions about other imaging options.
Yeah.
How do micro ultrasounds and BP MRIs fit into this?
Okay, I love it. I love it. Okay, so micro ultrasound is a ultrasound. It's a transrectal ultrasound that we use for mostly for biopsy. And I actually use micro ultrasound for almost all of my biopsies. It's a higher resolution image, and we participated in a trial showing that it actually is equivalent to doing an MRI for detecting prostate cancer. And so I'm not sure it's better, right? So I think an MRI is still important because MRI tells us where to look and looks for changes in the prostate. So I don't think a micro ultrasound is a replacement yet for an MRI, but I use it in the process of doing a biopsy.
Test 1, 2, 3, test.
Oh, we can hear you now, Jeff.
The second
Jeff,
question
why
about
don't you-
oh, sorry, yeah.
Yeah, Rochelle, do you have something else?
I think Dr. Leapman was still going there, so I'll
There was a question about biparametric MRI. I see that in the chat too. So it seems to be just as good as a multi-parametric MRI. So the MRI is done, it's an MRI, you go in and it's scanning you're looking at your prostate. What biparametric means is they're doing the anatomic phase, they're looking at the prostate, and they're doing what's called diffusion weighted imaging, and they're looking at how water molecules are moving within the prostate. And areas where the water molecules can't really move around too much are more suggestive of having cancer. The multiphasic one is when they add contrast injection. So they put an IV in and they give you a contrast agent that goes everywhere. And it lights up areas with more blood supply. And so that was the standard for a while. It is a standard in many places, but there is a lot of evidence showing that biparametric is just as good as multiparametric for picking up prostate cancer.
Yeah,
So
let
I don't,
me
Yeah.
interject here too, that 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 a lot of the experts in this feel like you really need to see somebody that is an expert to be able to read it correctly. So, it's,
yeah.
and then also, any rate, Rochelle, keep going.
Well, that's an important question because right, that's right. MRI, this is one of the tricky things. Like, if you have a PSA blood test, you go to the lab, that's going to be drawn on a machine that's pretty reliable. I don't think you need to worry too much about your PSA, right? If it tells you a 4.2, it's somewhere in that range. The MRI, who reads it is probably more important than if you had contrast, because an expert radiologist who's looked at lots and lots of these and knows what is well calibrated on this is really, really important. There's some interesting studies published where they compare, even at expert centers, even at top institutions, individual radiologists reading the same MRI will give different PIRAD scores. And so it doesn't mean that it's worthless, but it's important to have it read by someone who knows what they're doing. AI is actively being deployed to help solve this problem. AI is actually very good at identifying prostate cancer on MRIs, and so we are not too far away from having that probably raise the tide for everybody. So MRI, very, very helpful. If you're offered a biparametric, I think that's fine. We are still doing multiparametric, which means the contrast for most people. Our radiologists feel like there's still an edge you get from that contrast agent, but I don't know that it's critical. I think getting the MRI is important though.
Some institutions like the University of Michigan, for the most part, have phased out the multi-parametric. But you mentioned something in your talk about how the biparametric can miss, some things you might want to look for. But personally, I look at that as a not a bug, but a feature, because those things, if they are going to turn nasty, you have time to keep monitoring them, and if they're that small, they may never mean anything.
Correct. That's an essential point is that, yeah, right. If we go looking hard enough, we might find the one tiny cluster of grade group two. But is that going to make a difference, right? I mean, so I think there's a big movement to understanding we want to predict the bad outcomes. We want to rule out the bad stuff, right? Picking up grade group two is what we call a surrogate outcome, right? We think it's helpful in predicting the bad outcomes, but it's not really what we care about. We care about finding the cancers that are destined to spread and cause and shorten someone's life. And if it's not going to do that, maybe we should, you're right, maybe we should slow down a little bit.
Yeah, Rochelle, unless you have something else, we'll move on to Jeff.
Just really quickly, I was going to ask about PSMA PET scans, just while we're on the topic of imaging.
Yeah, great question. I see that from David Peterson in the chat. Yeah, very exciting. There are studies underway across the world looking at PSMA PET in active surveillance. PSMA PET is what's called a molecular imaging test, okay? And what PSMA is a protein that lives on the surface of prostate cancer cells. It stands for prostate-specific membrane antigen. It lives in the cell membrane around the cell. And what they figured out is they have made a dye, a tracer, that will stick to prostate cancer cells and can fluoresce and be detected on a scan. And it has revolutionized the staging of prostate cancer. And so it's very good at finding metastatic prostate cancer. So we stage all of our patients with intermediate and high risk prostate cancer using PSMA. Whether or not it moves the needle in active surveillance is an open question. The risk of metastasis is pretty low, so we don't think it's so helpful for that. It's more for finding the tumor within the prostate. So right now, it's not recommended. The official guidelines discourage doing a PSMA PET for low risk prostate cancer. I wouldn't. So I do not recommend my folks going out to get a PSMA PET outside of a clinical trial.
So is that more of an economic issue than
Well, not really. I mean, yes and no. I mean, I think my primary concern is that are you going to go have a false positive, right? And meaning, and I've seen it. I've seen plenty of people who've gone out and gotten the PSMA PET because they wanted it, and it finds maybe something that's questionable. I don't know, and it motivates some invasive treatment that was actually false because those tests were developed for high risk and metastatic prostate cancer. When you take a test that works well in that setting and you apply it to a new setting, you get different performance. And so you get more false positives. And so the jury's out. Hopefully we'll find out, but we have MRI already. So it's not, even if it's free, it's really a question of, is it going to help us find what we're looking for?
Jeff, how about you dive in?
Hi, can you hear me?
Yes.
Thank you. Yeah, I had some new technology. Doctor, again, thank you. One of the things that I've experienced 15 years now in active surveillance is information. How do I manage all of this information? Now, the first 5 years for me was trying to understand the terminology, and then the terminology changes, and then the technology changes, then the doctor changes. So I think it's a challenge perhaps for both the doctor, the clinician, and the patient. So what I'm really getting at is when can we begin to merge changes in technology with our care? And what I'm really talking about is artificial intelligence and what necessary controls come with those. But nonetheless, I got to believe that machine learning is going to take the anxiety level down for both the doctor and the patient. What do you think?
Absolutely. Yeah, I think that's a very exciting development. I mean, if you think about it, the amount of data that any one person has in their chart, even if you have a great doctor, there's a lot to keep track of for the physician or for the patient. What are all my PSA levels? What are all my comorbidities? What are all of my test results, right? And if we begin to develop true multimodal artificial intelligence, which is incorporating imaging findings, biopsy findings, genetics, genomics, other lab values, other medications, other exposures, I do think we may get a more personalized approach. Um, I think that's the long-term vision is that you will have a very complete story about yourself, about your overall health, not just, prostate cancer being one of those chapters in the story, but your overall health will be, more well defined in the short, I mean, immediately, I have a number of patients who come to see me and they are already using AI, Claude or whatever, to organize their records. Um, we don't do this yet because there are, privacy concerns about feeding patients records into these things. So we never do anything like that. But I do see patients who use these tools to organize their information.
And that is good. Thank you, doctor. Now, another question, if I may. What is this new concept of super agers and how does it relate to, if you will, the lifestyle? I tend to follow it. I'm 73, blessed so far with good health. But I still have in the back of my mind, hey, you're 3 plus 3, don't go crazy and start barbecuing and burning your steak and all these other things that Dr. Dean Ornish and Dr. Ordell used to talk about at UCSF back in the 70s. So tell me, we want to be a super ager and we want to live long and keep the prostate under control, how do you merge this new thinking?
Yeah, that's the big question. I agree. I mean, I don't know that I have a simple answer. I mean, my rudimentary, simplistic way of thinking about it in my own life is, I think a good lifestyle is going to be good for everything, right? And prostate's no exception. So I truly believe in a holistic approach, right? And I think all of the evidence we see in prostate cancer, and there is some about diet and exercise. We're actually launching a trial of high intensity interval training among men with more aggressive prostate cancer. There was a study done in active surveillance patients looking at high intensity interval training, showing some, early positive effects on, um, you know, gene expression levels and PSA kinetics. So, I think if people are living a good lifestyle, I would not take your foot off the gas, and I wouldn't look, and a lot of people tend to find their diagnosis as a defeat. It's like, oh my, I've done everything right and I still got prostate cancer. See, what's the point? But it's actually the opposite, right? If you're, in a way, if you have 3 plus 3, maybe that's maybe it would have been a lot more aggressive, right? And so, um, I would lean into it rather than say it was it wasn't worth it.
Okay. And I appreciate that because I think as we climb Jacob's ladder, if you will, unlike our golf game, we really want to control our outcomes, and that would be very helpful. I have one final question here in terms of let's see here. Uh, Darn it, I had it written down here, but I think perhaps if a family knows they've got a history of men and perhaps women with cancer, I'm talking about the BRCA gene and the
Yeah.
interchange, if you will. Um, how soon should we be telling our children and our grandchildren, hey, you better put this in your medical file? What do you think?
Yeah, it's a great question. I mean, I would distinguish a family history from like a clear genetic alteration, right? So if someone has a known BRCA2 mutation, ATM, any of these, really fundamental genes related to cancer development, it's really, I think, important to, meet with a genetic counselor because prostate's one of the pieces there, but we're talking about colon, pancreas, you name it. But I would start if I with a known BRCA2 history. So if someone's child tests positive for it, I would start even at any age in the third. I mean, well, not in the 20s, but in your 30s, because I've diagnosed people with BRCA2 in their 30s. Family history, right, is very different, right? So family history of low-grade prostate cancer, since we know that's almost a passenger for many people. I do test earlier, start testing at 45. But I kind of try to put things in perspective. That doesn't mean this is barreling towards anybody. So we want everyone's kids to not feel like there's a elephant sitting on their shoulders that is coming for them. So you gotta, I think, you know, temper how we describe it.
And then finally, just maybe food for thought. I don't expect this final answer, but there's a lot of people that live in a rural area, be it the US and Canada and Europe and Asia and Africa. My heart goes out because we have all these wonderful things in our urban world. But what about these men and their families who are in a very they don't have access to a good clinic?
Well,
Yeah.
Jeff, you make a good point there. Many, many counties in the United States have no urologists, and probably a number of men on this call are driving maybe 6 hours to see a urologist to manage active surveillance, and same sort of problems with more advanced cancer. So it's a bad situation, and and they're not training enough urologists in the United States, I don't think, to fill the gap. But
Yeah, wow. I love that question, Jeff. It's very, very thoughtfully posed, and I agree. Yeah,
Well,
this is I will say there is some optimism here. I mean, look, here we are. We're meeting across the world, and we can get this out there. This probably wouldn't have happened 10 years ago. So through
we
communication,
started almost 10 years ago, so we've
yeah. But
again,
now everyone, I mean, but
yeah,
Zoom, but I feel like everyone is used to hopping on a Zoom call,
yeah,
and so
well,
technology is making the world smaller.
sure.
The we need to think about scalability. I'm totally with you. Like, what's the point of doing things if we can't scale them out? Why are we doing it?
Yeah.
I participate in a service called Grand Rounds. It's called or Included Health. It's a company that offers telehealth consultations, and I think it's pretty cool because I get these cases that come into me from people all over the country and sometimes out of the country, and the records it's all streamlined and it all works. So telehealth, I'm not sure it's going to solve every problem, but um, you know, and they want to take it away from us. I mean, there are all sorts of regulations about where we can practice. Like, I can't do a consultation outside of Connecticut and stuff like that. But um,
well, let me ask you, how do you do a digital exam over telehealth?
yeah,
Ah,
We're
yeah.
just,
You
there
don't.
you
I mean,
go.
that's a great question because, yeah, should we even be doing digitals, right?
well,
Um,
yeah, well, I assume not, but I know they are working on remote digital exams. Sounds a little
Yes.
bit weird, but I want to take you back to something you brought up earlier, which is anxiety. We did a survey with a group in Canada and ANCAN, and we had 450 patients in the survey, and 50+% of them had anxiety levels that were high or other emotional distress. And 10% of them had it so extreme that even though they were, say, Gleason 6, they were seeking active treatment.
yeah.
But I'm wondering, you know, I'm not going to ask you to speak for the American Urologic Association, but they have no recommendations for screening for emotional distress. They do for testicular cancer, but not for prostate. And
Hmm.
I want, I got a question here from Ken Schellenberg, who, in the context of de-intensification, he suggests, well, he said, I suspect decreasing testing would increase my anxiety about cancer spreading unchecked, which would lead me to treatment prematurely. And so he says, how do you balance less testing and more anxiety?
Wow. Yeah, that's really that's so important. I think I need to feed that back. I will feed that back to the AUA and SUO and we should be screening for distress. I mean, I think some of it maybe it's not explicitly mentioned because we should be doing that for everybody who comes in our clinic. Even if you don't have prostate cancer, if you have elevated PSA, I mean that still causes anxiety. So 100% we should be doing that.
Well,
Um,
the American College of Surgeons and other organizations say what you say in terms of any cancer. It should be screened
yeah.
the patient should be screened, but
And 100%. And then it was a question of, well, what if we can screen, but what do we do about it if we have a positive screen? Because then you need the whole integrated network. Who do you refer to? That's actually part of the reason that sometimes the guidelines don't say that, because that always comes up is, well, we don't have the right resources. Where we get, but we should, that's not a reason not to do it. We should be doing it. And to the question of, well, yes, does more testing reduce my anxiety or increase it? And that is, I think, the art of this. It's not a perfect science because everyone's different. And if a gentleman tells me that he's going to feel better if we do the tests every 4 months, we're going to do this test every 4 months. Why wouldn't we do that? So we need flexibility to practice in ways that kind of give people where they want, meet people where they are, and and not try to jam a one size fits all approach to everybody. Give some guidance and give some scientific, give some evidence-based recommendations, but allow flexibility for what people want.
well, maybe I notice in our audience today is a gentleman I know well who's in his mid 80s. And it seems like all the time he's asking, should I continue with surveillance? He says, I've gotten a lot out of it, but maybe it's time to stop. I know another guy in his 90s, or another guy who says, he's going to keep doing this into his 90s. What's the problem? And just wonder, how age fits into this whole issue of testing.
Yeah, yeah. Age is the thing. That's really what this is all about, honestly, is age, is what are the competing risks? And so I don't know that I have a strong feeling about that we absolutely must do yes or no, but I think what we should be doing is providing information that if you've lived into your 90s and you have low-grade prostate cancer that hasn't progressed, I think we can confidently say that the risk posed to you by that cancer is incredibly low, and let people do with that information what they want. But we just need to generate that and communicate it.
Matt Cooperberg, Dr. Cooperberg, once took on that same question. I was talking to him, and he mentioned a patient who'd been on surveillance, I swear, for like 35 or 40 years. And he turned 101 and developed an aggressive cancer. So, what do you do with that?
Yeah, you're right. I mean, that's the other thing. So cancers get more aggressive as we get older, right? I mean, that's the not to throw a wrench in this story. It's very, but there's some, in general, cancer is more common as we get older, and they get more aggressive as we get older. So, the odds though are low. I mean, that's why these are notable cases because they stand out.
Gotcha. Well, I think we're about our our scheduled quitting time, but I'll ask the other moderators if they have other questions to bring up.
Could I sneak
Um,
one in? Sneak one in?
It's not sneaky at all, Jeff.
No, I'll stick around as long as people want to chat. Yeah.
One of the things I ask myself is about culture. Now, I've been involved in mental health for a little while, and I know there's, the Native Americans and the Native Canadians and that use different substances, which I won't mention for legal reasons. However, it seems that over the years we've had the Asian culture has used a lot of things such as mushroom powders and that. I'm wondering, doctor, if you care to comment about that. I'm just trying to bring the world together, and maybe we could learn something.
Yeah. Yeah, I mean, I think this is an area that's underexplored. We did a randomized trial of a fermented soy product from China, actually, in men prior to surgery. They had more aggressive cancer. We didn't see a strong signal. Um, I'm all for it. I mean, I think if people want to use complementary medicine, as you know, I'm all for it. But I do need to be careful just in when folks ask me, well, is there evidence for it? Unless there's something that I can point to, you know, I'm sort of agnostic on the question. But
Yeah,
we got to do the
David,
studies and be open-minded.
yeah, thank
David,
you.
you got your hand up. You don't have to be so formal.
Okay. Thanks for sticking around, Doctor. Really appreciate it. When we talked about biomarkers, genomic testing, we talked about Decipher, and I think my prostate score was actually, it wasn't, I don't think that was genomic. That was like a urine test.
Yeah.
But are there tests that you think your patients would benefit from? Like a Decipher, like a my prostate score. Is there should we add any others to that list that we should consider when we're trying to develop a good database?
Yeah. So, it's all over the place, right? I mean, because Decipher, I think, has the most evidence for it as a prognostic marker, right? What we're working on as well, what does it tell us about, the low risk patient? Because the risks are so small anyway, right? So are we going to have enough resolution to tell the difference between someone who has a 3% risk and a 1% risk? And maybe we won't, I'm not sure. So in my practice, though, I do offer Decipher in many people. But I will tell you, if someone has an infant, has 1 millimeter of Gleason grade group 1 and a low PSA and a good MRI, I usually don't order the Decipher because I'm not sure what it's going to tell us. I use it for those edge cases. So I wouldn't say you need to go out there and get every test that's out there. I sometimes that actually can cause a lot of, cognitive confusion. You got 5, 10 different signals and there are a ton out there.
Well, and
David, I think you muted. Yeah.
we
Yeah.
had
Just one last question, if I have time,
sure,
Howard.
you got time.
Aquablation. I know this is, well, since 2017, I guess it was approved by the FDA. My understanding is that if you have a lesion or suspicious cancer in the transition zone, that aquablation, that's where they remove cells. They put the hose in there and they're squirting out prostate cells in the transition zone. We had a speaker that said, yeah, if there's a cancer in there, you can't, this is not an FDA approved statement yet because it's in clinical trial, but that, yes, as it's squirted out cells in the transition zone, it's possible that a number of those cells could be cancer cells. Is your group looking at that at all?
Great question. So yes, I mean, there's a trial underway where they're treating people with prostate cancer using the aquablation. So we got to see what that trial shows. I am not treating people with aquablation, outside of, and I don't think we're participating in that trial. So outside of a trial, I would not, I would definitely not do that because, I just don't know. I mean, that's blasting things with high pressure. Who knows? So if there's an aggressive cancer, I wouldn't use aquablation. There's a big interest in ablation, using heat, ultrasound, cryotherapy, electrical current. And that's also needs to be studied more. I mean, I know Howard and I have shared some emails about it. I'm also open-minded, but not an evangelist for those because we need longer term data. The data always looks good in the first 5 years because these cancers rarely do anything in 5 years. So what we need is all these investigators to kind of lean in and commit to doing long-term studies to answer the questions that patients desperately need to know. Because yeah, maybe we can be doing these less invasively.
Thank you. Back to you,
Hey, I
Howard.
have an ethical follow-up to David. A patient just north of me in Wisconsin was approached by his urologist. I think he's on this call today too, if he wants to chime in. Doctor suggested he join the Water 4 study, which is a
Yeah.
big international study. And the thing that blew him away was that the study was open to Gleason 6 patients. We, I asked my own doctor about it. He said he would never do that. But what's your stand on that? Is that ethical or unethical?
Well, it's a trial, right? I mean, so I think for low-grade prostate cancer, we think that it's well in the spectrum of normal, right? I mean, it's not that far out, and if it has low metastatic risk, I get the theoretical reason to do it. Um, so I'm not opposed to the principle of or the idea behind that study, but I think I would counsel a patient, look, hey, we just don't know what could happen. Maybe this will get rid of it, but there's potential, at least in theory, that I could imagine from pushing this thing really hard and vaporizing it. Who knows what happens? So.
Gotcha. Well, let's take one last poll. Anybody else with a question? And anybody from the audience want to raise their hand? And I think you're off the hook now.
This was really fun. This was really fun. And Howard
Yeah.
and the whole crew, I can't thank you enough for what you do. I mean, I've pointed a lot of people in your direction, and I'm just honored to be a part of it.
Well, we should mention the new booklet that ASPI put out, sort of a guide to the path of active surveillance. And Cooperberg and Klotz reviewed it. And Jeff, can you put that in the chat?
I'll
Which
put it in now.
Well, the chat, or Rochelle, can you put that in?
Well,
William Jones, you got a question.
Thank you. I'm just scheduled for a perineal biopsy. I've had three in the past, and I'm just wondering, my Gleason 3+4. I'm just wondering what this new one will find out that the others already haven't found out. I did an MRI back in the spring, so so I'm just wondering, I'm rescheduling the biopsy. I just was wondering what do they hope to find from this one that they haven't already found out?
Yeah, speaking generically, what are they
Yeah,
going to find?
I will speak generically. I would say a few things. Number one, for general people that I see with 3-4, always a bit more cautious, right? So I think higher degree of caution for 3-4s because those are higher risk. Still good, still very good outcome at higher risk. So I think overall more concern for 3-4s is warranted. It kind of depends on the timing in general, so if the other ones were, a few years ago, I think that third one, makes sense. If there's a change on the MRI, let's say if a lesion looks more conspicuous, larger, then that would be a trigger to do it. PSA changes. So biopsies are not bad. I mean, they're telling us the information that we want to know. Big question for 3-4s is what are they looking for, right? Would 3-4 is usually the outcome where we treat people. So if you have a 3-4, what would it take you to be treated? Is it having a 4-3 or 4-4? That's probably what they're looking for.
Do you ever consider surveillance for men who are 4+3?
Yes, in the right person, right? The person who's strongly motivated, who says I don't want to be treated. Well, that's easier, if you don't want to be treated, and there's some people who absolutely do not want to be treated. Folks who are older, significantly older. If you're close to 90 and you got other health issues, then don't worry about that. And then sometimes it's a sampling issue. Sometimes we get a 4-3 because we just happen to sample the tumor in a way that it made it look like a 4-3, right? Because we just happened to catch it tangentially, and there was more 4 than 3 in that little core. So why should that? If we took out the prostate, we're probably going to find that it's overall a 3-4. So those are cases where the MRI is very helpful to adjudicate the story as well as the genomics and things like that. So a lot of complexity, a lot of heterogeneity in the intermediate risk group. So this is why we're super focused on this question because there's a lot to figure out.
Yes, Stephen.
Yeah, thanks, Mike, and to the whole organization that pulled this off. I got only snippets. I had a TERP surgery yesterday, so was unable to see
Yesterday.
the whole program.
Well,
One question. It has to do with the 29 pathologists that run counter to some of the ingrained thinking today. Would you want to make a comment about the angst caused by the industry itself in terms of reports like the pathologist saying that we consider GG1 a cancer?
yeah, yeah. I mean, that's a great question, right? I'm sure you've had Scott Egner and Matt Cooperberg and people weigh in. There's a movement to relabel grade group one something other than cancer. Um, And yeah, it's complicated. I mean, I think that, the pathologist, I see both sides to it. The pathologists, do talk about they're looking at it very scientifically, looking at the molecular characteristics of those tumors and the morphology of the tumors. And so their argument is that it meets the definition. I think the other question is more, I mean, these are like epistemologic questions of like, well, what is a cancer? What does it mean to be a cancer? I mean, is it about the ability to spread and just about everything has the ability to spread. So um, you know I'm not sure that it's a simple answer, and then again, should we change the name just to take down the anxiety? The anxiety may be there, and what are the second and third order consequences? If someone is told they don't have cancer and never gets follow-up and develops metastasis, what happens? So
Yeah, I'm
I
gonna,
won't, yeah, I won't wade too much into that, but I think that the intentions are good on both sides, but we need to hear from you on this because most absent from this discussion are patients because that's what we really want to hear from. I've heard from many patients that they actually oppose a relabeling for that reason. So,
yeah, well, I mentioned that our survey with 450 patients, and that was presented at ASCO.
yep,
And any rate, what we found was only 5% of our respondents said that they would stop surveillance if Gleason 6 were renamed as a non-cancer.
yeah,
So uh,
yeah.
so
Fascinating.
just
We should really leverage the ASPI organization to think about how to really ask patients in an exhaustive way, ask the right patients, ask people from all walks of life, and
yeah, well, that
yeah,
was one of the defects in our study because groups like this, minority men tend not to attend. And so I had mentioned in a presentation I did at ASCO remotely, I mentioned one of our problems was we had very few African American respondents. And so 2 days later, a researcher from the CDC who heard me called me and said, would I like to help her refield a study? And she was very, uh, I don't know, dubious, but she's the one who approached me. She kept saying, oh, we'll never get the funding. Well, we got $1 million, which I thought was chump change, but I guess was pretty good for an active surveillance study.
wow,
And a year ago, it felt like we were going to lose funding because of what was going on in Washington, of course. And but no, we're in our second, moving into our third year, and the CDC is talking about increasing our funding. So,
it's
but then,
vital. It is absolutely conspicuously, you guys have to be at the center of this question.
well, I'm an advisor to
Yeah,
to this. This was my idea to begin with, and Cooperberg and Loeb are leading it,
yeah.
and yeah, I think it's going to be interesting. But anyway, Mike Wynn, weigh
I,
in.
thanks, Dr. Lippman. I got two questions. Number one, I guess is implied that we cannot have telehealth if you're not in Connecticut. Am I correct?
Yes, that is yes. I mean, it's for a formal consultation. I think this is just a regulatory thing, but you could always check what call. It depends where I'm happy to talk offline. Depends where you live. But there are some strict rules, about
Okay. Second question is that I read that essentially, even with surgery or radiations, the biochemical recurrence is pretty high. Is that due to the fact that the cancer cell that did not get killed use the evolutionary force to become more virulent in the future?
Yeah, I mean, although biochemical recurrence usually is in the setting where no more treatment has been given, right? And so recurrences after surgery or radiation are typically because, there are cells that might have gotten outside of the prostate. That risk is very low for grade group 1, but for grade group 2, it's not zero, right? And even for grade group 1, it's not zero. So there can be local, so it's really two causes. One, local recurrence, right? Like just some cells around the border that were not removed or killed with radiation, or something that has microscopically gotten out and wakes up 5 years later.
In the simple term, the ones that do not get killed, do they get stronger and become more virulent with time?
Generally not with time, but with our treatments. This is really a fundamental the fundamental question in metastatic prostate cancer is when we give hormone deprivation, at first it works very, very well. It causes the cancers to regress or many of them die. But you're correct. The ones that do not die undergo a sort of an evolutionary selection pressure and are more aggressive. So we still think for metastatic prostate cancer you have to do it, but it does induce what is called this transition called lineage plasticity, where the cells actually change and they stop looking like adenocarcinoma, like the typical prostate cancer, and they become in the family of what's called a neuroendocrine tumor. So lots of very complex things happen in this in this treatment resistance mechanism, and we have a whole lab, multiple labs in our group that are studying this. Labs across the world and the country are studying this because it is incredibly complex.
Last question that I made. In your presentation, you talk about grip reform. There's some uncertainty to that. Let's continue to study about that. But when you answer the question, you said if you have grip reform, you need to have treatment right away. Is the quantity of grip reform glands and the size of that important decision whether you need to take treatment or not? For example, if I have one single sample out of 30 samples get grip reform, let's say large grip reform, is that determination for me to take treatment?
That's a great question, right? This is something there's a lot of research happening on this right now. In all of the evidence that we have, in the PROTECT study and all of these, they didn't quantify the amount. They said if you have any cribriform, we consider you cribriform, because of course more is probably worse, but any determination of cribriform was associated with higher risk of spread.
Thank you.
Okay, one last try, and if no takers, we'll give Dr. Leapman the rest of the day off. So going once, going twice. Michael, it was really good having you here. I think it was a great program, and maybe we'll have you back if you can put up with us one more time or more.
I would be honored. Thank you.
Thank you very much.
We're honored.
Thank you.
Have a great weekend, everybody.
Thank you.
Thank you.
Thank you.